and research. So we all know what theory is. It's basically an idea, an understanding, a belief of what something is, how it operates, how something operates, the effect that something has on something else. So theory, we use it in everything. We all have theories about things. They're beliefs, they're assumptions, okay? Some supported by research, some not. Some are just what we believe, maybe based on experience, family background, upbringing, the way we view the world. When it comes to clinical interventions, theories, they also derive from, various experiences or outlooks from the folks that develop them. And of course, like I said, we'll talk about that with each one. But we need theory. We need theory in counseling, okay? We need a roadmap that kind of guides us, gives us a little bit of direction in terms of where are we going with this client, okay? So it helps us to develop a specific form of a helping relationship. We talked about that a little bit earlier as far as the client-therapist relationship. That takes on a form. It almost takes on a life of its own in some respects, but theory guides us in shaping that relationship, helps us to understand what's important about that relationship, how it's used in the type of therapy, okay? It gives us a more useful understanding of the client's situation because it gives us a lens, okay? We're looking through a particular lens that helps us understand what that client's going through and how he or she got to that point, okay? So we're gonna be looking at several different lenses this semester in terms of understanding how did they get there? And then of course, how do we intervene to help them resolve those issues? So we're figuring out effective needs. Okay, so I like to think about it as a lens, as a structure, as a roadmap, if you will. It's not enough in the counseling session to just, we want to be, empathic, non-judgmental, understanding of the client, view them with unconditional positive regard, but it's more than that. We need to have a structure, we need to have a theory and a roadmap. So in counseling theory, competency, we're talking about common threads in the use of theory. We're gonna have, we're gonna see common threads essentially in each one of the theories that we use. And we'll get to this sort of at the very end of the semester where we talk about this whole idea of in a sense, pulling the common threads from particular theories and almost creating sort of a common thread approach, if you will. So it won't be uniquely one or two particular approaches, but taking those common threads together. So competency, what does that mean? What does it mean to be a competent counselor? Okay, what does competency mean? It means having, competence in multicultural issues, a multicultural understanding, a multicultural view. Diversity, recognizing diversity. What are differences among people? Okay, what are particular customs and beliefs and ways of seeing things that are unique and different to different populations? We're competent when we recognize that, when we seek to understand norms and customs from cultures different than ourselves, than our own. Research competence, what does that mean? Research competence means it's our responsibility as social workers to be up to date on research. okay? What kind of research is being done on effective treatments? Turns out quite a bit of research is done on particular types of interventions. A great example of that is cognitive behavioral therapy. If you're practicing cognitive behavioral therapy, you know, we have to show competence by keeping up on the latest research that's being done. But more than that, we need to keep up on what the latest research is with clients with particular issues. What if we're working with someone with an eating disorder? It's our responsibility to know what the research and what the literature tells us about most effective treatments for particular populations, okay? So, because we don't go in with a one-size-fits-all approach. Okay? We go in with an approach that says, what is the appropriate theory for this particular person with this particular problem at this particular time, okay? So, in other words, the difference really is if you're a clinician and you know you have 3 patients scheduled for the afternoon, you have your 1 o'clock, your 2 o'clock, and your 3 o'clock folks scheduled. Does it mean that your patient that comes in at 1 o'clock, you're a particular type of therapist? So the therapy you feel comfortable and feel competent in providing, it's a therapy that they're going to get regardless of who they are, regardless of their problems, and it's the same therapy that your patient at 2 o'clock is gonna get, even if their issues are completely different, the same therapy that your client at 3 o'clock, because you are kind of this is a terrible way to say it, a one-trick pony. I mean, you have expertise in one particular area and you apply that to everybody, okay? And there are therapists out there that do that. And in some instances, my personal opinion is that there are some particular areas and groups of individuals that we really need that. We really need a great amount of expertise in a particular theory. An example of that would be DBT, dialectical behavioral therapy, because it's a highly specialized therapy for a historically very difficult group of individuals to treat. And so that's kind of an example of a theory that really we want to really, you know, if that's what we're going to practice, we have to get really invested in that particular theory. But then back to my example of the practitioner that has their client at 1 o'clock, 2 o'clock, and 3 o'clock, 3 completely different people, 3 completely different problems. So then is that therapist saying, oh, okay, my 1 o'clock patient is so-and-so with these problems, and I know that the literature says, that the research says this particular intervention is most effective. That's what I'm going to utilize. My 2 o'clock patient, completely different person. Well, this is the approach that seems to work best for her. That's what I'm going to utilize. And so on and so forth. So you can see the difference, okay, in how we sort of approach therapy. And example number 1 is certainly more typical, you know, certainly what our history has been, because our history really hasn't been all these different approaches. One of the dangers in that, though, is, you know, we can't really, I think it's fair to say you can't gain a great deal of expertise in lots and lots, you know. I think in order to be just really effective, really knowledgeable, really competent, you know, we gain some expertise maybe in the most widely utilized ones, and so that we can know, this is the right match for this type of treatment. Okay, so, and then a huge thing is what the research shows. And I don't think that a lot of people think about that in social work, do we? We don't really sit there and think, this is what I want to do in my career, this is who I want to work with, but what does research say about what's effective with these particular individuals. A lot of times we don't really seek that out specifically, and it's important to do that. It's important to stay up on what's happening out in the research world. Laws and ethics, of course, we need to know everything that we are held accountable for, ethically and with the law. And I went ahead and just put the NASW Code of Ethics on the module so that you can have some nice, light, easy reading for your, Saturday night. Get your little glass of wine, get your little margarita, and open up to the NASW Code of Ethics. But it's important to at least, take a look at and know what you're held accountable for. Know what the standards are that apply to you. That's part of being a competent counselor. Person of the counselor. Who are we as a counselor? What do we bring to the table? Okay? We need to know ourselves. We need to know what our biases are. We all have them. No one could possibly say that they don't have a bias, because they do. Everybody does. The issue is to figure out what they are, be honest about them, figure out how to challenge them and change them. Okay, and we have to be honest with ourselves, and we have to be willing to do the work on ourselves to change those biases, to confront them and change them. Person of the counselor, it also, another few examples might be, self-care, taking care of yourself, knowing when you have reached a point in time that you're not being effective right now. You're burning out. You're really at a point that you spread yourself so thin that you're losing some effectiveness with the client and with your agency and with your work setting. We have to take care of ourselves. We have to know when we've reached that point. Person of the counselor might also mean that we need to be aware of how others perceive us. Because we're all looking at each other through a particular lens. So you need to be aware of how your clients might view you, okay? It's not a right or wrong, it's just it is, okay? So, our clients are making assumptions or believing, something about us. We're in the room. How we present ourselves. It could be just characteristics, our race, our clothes, our presentation, things like that. So we have to be aware of sort of those conscious and unconscious kinds of assumptions and perceptions, okay? Person of the counselor also has to do with empathy. We're gonna talk a lot about empathy over this semester because it is crucial, it is imperative, it is essentially the foundation of counseling. The ability to empathize. And that doesn't mean sympathize. We're not feeling sorry for someone. We're not sympathizing, we're empathizing. That's putting ourselves in someone else's shoes and seeing things from their point of view. That's what empathy is. Okay, so I've kind of covered this up here. There's research that's being done in terms of common factors, where research is being done on effective treatments, but also what are the common factors across the theories that can perhaps be merged and integrated to essentially form a unique approach. And then, we mentioned evidence-based practice and treatments. Diversity and multicultural competence, we kind of touched on already. Competency in terms of, you know, all of these different characteristics about an individual and about ourselves as well. An awareness, a sensitivity. If we don't know, then we learn. You know, what about differences? Or what about people with different religions that may have particular beliefs and understandings that may not be pathological, may be perfectly, perfectly accepted and perfectly normal within their culture and within their practice. Socioeconomic status, race, gender, sexual orientation, gender identity. Okay, that's one to really seek to understand what those issues are. There's a lot of, you know, discussion about that right now in our culture. These very, you know, heated topics and heated debates. It doesn't matter one bit what our personal beliefs or views are about it. Our responsibility is to understand, to seek to understand those issues, to work effectively and ethically with our clients. All of this is covered in the NASW Code of Ethics, confidentiality. Who knows what the laws of confidentiality are in Texas?
There's three.
Okay.
There's three. I think it's harm to themselves, harm to the child, and the disabled.
Well, it's a threat of harm to oneself or to someone else. Okay, so that someone else can be anybody, but also suspicion of child abuse or neglect. Okay, and so the law requires us to break confidentiality for those types of issues. But there's a lot of things that, you know, the client is protected by confidentiality, and we need to be aware of what their protections are to make sure that we're not violating them. We need to make sure we're practicing within our scope of competence and practice. If we have a client that we are not prepared to work with, that we are not, you know, able to appropriately provide services to, the ethical thing to do is to transfer them to someone who does have that expertise. Dual relationships. What's a dual relationship?
Being someone's friend while also giving them some therapy.
Yeah. So we can't be, if we're providing, you know, individual therapy to someone, that person probably shouldn't be our child's teacher. Okay? That person, you know, some years ago, I knew of a lady who, she was working in MHMR and was working with one of the clients, and then lo and behold, she, for whatever reason, decided that it would be okay to pay him to cut her lawn. And so, needless to say, that was a pretty immediate termination. So that's a dual relationship, okay? We can't receive a service from a client. We're there to provide them services, okay? So I think you all get the idea. You know, it's inappropriate to socialize with a client, okay? To socialize outside of the office, to have, you know, we have to maintain proper boundaries, professional boundaries, okay? We know the obvious ones, you know, in terms of the personal relationship. You may not be appropriate to have relationships with any of, a client's family. And I know some of these things are a little bit harder in like small towns, things like that, where, the places that someone goes for services, there's not very many. It's not like there's a lot of options. But, when your minister's wife comes strolling in for counseling, you shouldn't be the one providing it, okay? So we wanna make sure we're keeping things very separate, very professional, blameless. Okay, let's see, personal concern. I feel like that's just kinda goes without saying, just a genuine personal concern. And then we talked a little bit about mandated reporting. And typically when we're having clients sign their, HIPAA and their rights to confidentiality, we need to say that everything we talk about is confidential. These are the couple of things that the law requires me to report should any of this arise. Okay, so person of the council and competency, we talked a little bit about personal characteristics. Next week is when we're going to talk more about identifying and managing countertransference. That concept comes out of psychodynamics. And it's a great concept, and it's something that everybody, no matter what work you're doing, whether you're a therapist or whether you're a caseworker, whether you're a medical social worker, whether you're in hospice, countertransference is extremely important to be aware of. And so we're gonna go into what that is and recognizing it and trying to deal with it within ourselves so that it doesn't cloud our work with the client. Helps us to maintain more neutrality. And then the therapeutic presence. That we're maintaining a therapeutic presence. What am I doing wrong here? Any questions so far on anything we've covered? Exciting stuff, huh? There's some research that's being done on exactly what makes counseling effective. What are the core elements of counseling that really, where's the benefit? Where are people receiving the most help? And so, some of the research, client factors, so that can have to do with motivation. For example, how motivated is the client? Did they present for therapy and asking for help themselves? They're gonna be a lot more successful than a mandated client who never asked for our services to begin with, and they're being forced upon them. A person has a lot, lower likelihood of success in therapy. So that's what that means, client factors. Motivation, resources, whether that be financial resources and the ability to access services. That might mean internal resources, as far as, like I said, motivation, but also insight, the ability to reflect, the ability to sort of take something in and be able to really learn from it. And then, of course, other resources such as family support, social support. Those individuals tend to, do much better in counseling. So that's what that means. The counseling relationship is really exactly what it says. It's the relationship between the client and the therapist. It has to do with the quality of that relationship. How accepted does that client feel? When you have a client coming into your office and you are demonstrating respect and empathy and listening, truly hearing what they're saying, and that might be a very unique experience for that person. Maybe they feel like no one's ever listened to them in their life, that nobody's cared to even get to know them, that somebody's not judging them. That can be very, very healing, very restorative for that individual. Okay, so there's kind of a uniqueness to the relationship itself that may be completely separate from the content of what's been discussed. It's the process of the therapy itself and the relationship that's developed. And Carl Rogers really tapped into that in person-centered therapy, but it's really, you can see how that in and of itself has shown to be a very specific, or a very useful thing. And then, theory-specific factors in terms of, this specific intervention working best. And I suspect that now that this number is actually higher. Hope and expectancy, we get better because we expect to. Maybe we don't get better because we expect to not get better, but it's almost like the reality follows our hope. Okay, and then kind of talked about this a little bit already, the models that have developed through research. And an example of this might be motivational interviewing. That was a model that came about as a treatment for alcoholism and addiction, and that actually research has really found very effective, but also effective in other settings. So that's an example of something that's evidence-based, but then has application to other issues and problems. Weight loss, health factors, smoking, things like that. Wow, I'm not good at that. Let me try to get that up there.
What was the example that you gave for that?
Motivational interviewing, that's one that we're gonna get to, but that's just an example of, an approach that was, came out of treatment for substance abuse treatment. And then, it's tested, it's researched, and it's found that really that model can apply to a number of different problems with that same efficacy. Okay, so, so motivational interviewing. Okay, so I think that is that all I have? I guess it is. So, anyone have any questions on that? Short, sweet, to the point? All right, so that's what that's an overview of everything we're gonna be talking about this semester. And I've posted your